Hello, I'm Norman Swan. Welcome to this satellite broadcast on psychiatric emergencies. We're coming to you across Australia through the Rural Health Education Foundation's satellite network. Dealing with someone going through a mental health crisis is stressful for everyone involved. It also, though, can be life-saving. So recognising distress early, not being afraid to tackle it, which implies some self-confidence about the situation, and managing the situation appropriately can make a huge difference to the person and the people around them. Tonight we'll focus on Australian youth, the onset of disorders such as bipolar and schizophrenia, but we'll particularly focus on comorbid substance use, because as you'll hear, that's what colours a lot of mental health crises. There are a number of useful resources available on the Foundation's website, rhef.com.au, but I'll come back to that at the end of the programme. But now let's meet our panel. Ian Hickey is with us. He's a psychiatrist from the Brain and Mind Institute at the University of Sydney. Welcome, Ian. Ernest Hunter is also a psychiatrist, and he's in the Department of Social and Preventive Medicine at the University of Queensland and is a regional psychiatrist in North Queensland with Queensland Health. Welcome, Ernest. John Rathtos is a senior specialist in emergency medicine, and he's both at St Vincent's and Sutherland Hospitals in New South Wales. Welcome, John.
Hello.
Chris Mitchell is a rural general practitioner from Lennox Head in New South Wales. Welcome, Chris.
Thank you.
And Fiona Little is a clinical nurse consultant in the Psychiatric Liaison Service at Tamworth, also in New South Wales. Welcome, Fiona.
Hello.
So welcome to you all. What messages do you want people to take away by the end of the programme? Professor Hickey.
Well, Norman, just like other medical emergencies, for psychiatric emergencies, you've got some skill, you've got some experience, you've got some confidence, you'll do a really good job.
The skill, though, I mean, for a general practitioner, you're not going to see too many too often, are you?
Well, a skill like other life-saving skills in the other parts of medicine, there's some skills you need to have. It's not an option. Many people walk away from psychiatric emergencies in a way they wouldn't walk away from a cardiac arrest or a respiratory arrest. So it's one of those skills you've got to have, and particularly for a GP in a rural setting, it's an essential skill for your community.
Ernest?
Norman, for those people working in Indigenous communities, I think it's critical to understand context, to utilise informants, to recognise comorbidity, both with physical disorders and with substance abuse disorders, to be sensitive to culture without rationalising pathology. And
by that
finally,
you mean what?
Well, that we need to take into account cultural factors that may inform the way in which people present. But just because something looks, for instance, that it may have traditional features, doesn't necessarily mean that it's a cultural process ongoing. And
so don't abandon your medical knowledge.
Never abandon your clinical vigilance. And finally, in terms of suicide, there are some key issues in terms of safety that relate to the use of substances and ongoing use of substances and providing supervision around those people at risk.
John?
Well, Norman, these people are in acute crisis that we're talking about, especially in emergency departments, and our job is to see them through the acute crisis and to minimise any risks. So I'm going to emphasise safety, and we achieve that safety through a skilled assessment as we'd assess any patient with illness.
Chris?
Norm, it's just a great opportunity for us all to lock in some really clear action plans so we can be more confident and competent in our daily work in emergency departments.
Fiona?
I'd really like to look at exploring some strategies, particularly with mental health acute presentations for the smaller rural sites, and looking at how GPs out there who have got limited resources can actually develop some skills in assisting them.
What's been your experience in that area?
That resources are particularly limited, and that GPs are basically the ones who are caring for a lot of the acute presentations in the outlying areas, yeah.
And in need of upskilling sometimes?
Yes, certainly, yeah.
As we all indeed are. On the line, I have Jonathan. Jonathan has had experience with mental illness and has had experience with acute mental illness and interacting with the system. Jonathan, welcome to the programme.
Hi, how are you?
We're fine. Tell us how tell us when you first became sick.
Well, I first began probably getting sick from about 14, but I didn't actually get diagnosed until 2003, so I think I was 16.
And what was going on with you at 14? What was going wrong?
Well, I came out that I was gay, so family life sort of went a bit imbalanced. Yeah. So, yeah.
And what, you just started behaving, you know, what, do you have thoughts going through your mind, or what was going on?
Well, I was just down a lot. My schoolwork was going down too. Yeah, I just wasn't with it most of the time. I was in my own little world, basically.
And were you using drugs at all at that time?
At that time, no, I don't think I'm not sure. I think I started using drugs either that year or the next year after that.
And what sort of things were you taking?
Mainly ecstasy and speed, but that led on to using ice and ketamine and marijuana and alcohol, and yeah.
What was that doing to you, taking that cocktail of stuff?
Depends in what year, but yeah, when I was 16, I started using a lot of drugs, so every weekend, and I started developing psychosis, and that's when I went and saw a psychiatrist.
And when you say, I mean, obviously, it almost trips off the tongue, you know, you develop psychosis, but tell us about that experience.
Well, from what my mum tells me, she said that I was usually very, I isolated myself a lot, and I wasn't communicating with people very well. I was often cheery and, yeah, not with it most of the time.
And you don't remember much of that time?
Pardon?
You don't remember much of that time?
I remember it, but yeah, I was just too paranoid to talk, I guess. So, yeah.
And when was the first time you can remember having what you might call a crisis?
First time I had a crisis in what sense? Sorry.
Well, I mean, have you ever felt like ending it all?
Pardon?
Have you ever felt like you know, that life wasn't worth living?
Yeah, I've felt that a lot of times. Yeah, and yeah, I've tried to commit suicide once. Yeah, so.
And what happened then?
Well, I went into hospital that night, and they gave me charcoal, I think, but I'm not sure. And yeah, I stayed in there for about 12 hours, and they set me off. Yeah, and they gave me like a counsellor and stuff like that. So.
And how was that experience, that interaction with the healthcare system, with the hospital and so on? What sort of experience was that for you?
It was, I don't know, I was sleeping most of the time, so I was knocked out from the drugs that I had taken.
And you had another experience of having to go to hospital as well, didn't you?
Yeah, on the day after New Year's Day, I went into hospital because I had too much ice, and yeah, went completely psychotic. So
and
that was a very scary experience.
And what did people do for you then?
Well, I went into the emergency room, and I think they gave me Valium, and put me to sleep for a while, and yeah, that's about it. They just they got me to see a psychiatrist, and yeah, and a doctor to see how I was going, and yeah.
You must have been scared.
Yeah, I was. I wasn't scared from the doctors. I was more scared about the stuff that I was experiencing. So yeah.
And how did they talk to you? How did they approach it to try and get you more relaxed?
Well, I didn't really talk much while I was in the emergency room. Nobody really talked to me much. They just sort of went, yeah, this is for this and this is for that, and that's about it. But throughout my stay in hospital, they were quite nice, most of them. So they'd be pleasant, and yeah, they'd say, oh, if you needed anything, just. And
you never felt that you were being judged?
No, I didn't. No.
How are you going now, Jonathan?
Yeah, at the moment I'm doing good. I've had a few ups and downs, but yeah, I've been off drugs for and yeah, monitoring my alcohol consumption now too. So going well.
And are you getting back to, you know, education, sort of uni or anything like that?
Yeah, I am studying at TAFE full time. That's going really well. I'm doing a lot better now. So yeah, and you know, not isolating myself so much anymore from friends and family, and yeah.
And are you on medication as well?
Yeah.
How do you view the future now?
Yeah, it looks pretty good if I keep going this way. Hopefully I don't get sidetracked again, but yeah, so far I'm feeling quite good about the future. I feel I'm happy now, so.
And what are the, I mean, what kind of situations do you see as a threat to going backwards?
I don't put myself in situations where I might start to get uncomfortable, because usually when I start to get anxious, I tend to start getting paranoid. Also, I don't put myself in situations where I'm open to drugs. So, yeah.
So you're learning to, in a sense, manage not just your drugs, but the environment around you.
Yeah.
Look, Jonathan, thanks very much for talking to us. It takes a lot to do that sort of thing, and we're really grateful.
You're welcome.
Thanks very much.
Okay, I'll see you later.
How typical is that sort of story, Ian?
It's very typical, Norman. I mean, the truth of the situation is 75% of the serious mental illnesses that we see start before the age of 25, and these days very likely to be complicated by a range of alcohol and other drug use issues. But I think the good part of Jonathan's story is that he has been able to get through perhaps the worst of things, is now getting reasonable care and learning to manage those other issues, and looks forward to a much better future. But it's required some critical medical interventions at certain stages and some people hanging in there and actually working with him through some pretty difficult times.
And Fiona, it sounds as if he was pretty well handled when he went into hospital.
It certainly sounds that way. I mean, aside from having to have charcoal, which is never a pleasant experience.
No, but
yeah, the approach from the staff certainly made the experience a little better for him.
Ian, take us through the sort of situations we're, you know, going to see here.
Well, I think the first thing to say about psychiatric emergencies is, of course, the issue is whose emergency is it? If you look at the hierarchy of risk, like who's actually going to end up dead or seriously injured in one of these situations, it's usually actually the person with the illness, or those they're closest to, like their family, rather than the staff. When you talk to many medical staff, they define psychiatric emergencies by the risk to the staff and operate on that set of principles. And that's quite difficult for us. I mean, there are situations in which staff, and we hear a lot about it, need to act in appropriate ways, set up the appropriate environment. But we have to also be careful that the focus of what we're talking about is improved patient outcomes. There are a lot of people at risk who are not necessarily perceived to be at risk, and there's a genuine emergency, their life's in danger, or perhaps their family's life is in danger, and we need to respond to that in both of our community and our hospital settings. A lot of the common disorders that we see, and we'll discuss a lot of the psychiatric disorders, really the emergency is not so much the disorder, it's the complication around acute alcohol and other drug use. And most of the emergency situations are almost defined as much by the substance use during a critical 12 or 24-hour period as they are by the psychiatric disorder that contributes to that kind of set of issues. And that really, when thinking about the issues, then one needs to talk about managing the risk rather than just what's the appropriate diagnostic grouping or the treatment for that particular diagnostic setting. And this has been particularly problematic in a lot of our stretched psychiatric services, where some diagnoses like personality disorder, etc., are used almost as a reason not to provide help, as distinct from seeing emergency risks, seeing situations that we can respond to, and in a productive way. When we talk about those psychiatric disorders that are commonly going to present, of course there are the psychotic disorders, which, as Jonathan said, are very frightening for the patient who finds himself in that situation. And particularly I'd emphasise for young patients who find themselves being psychotic for the first time. They will be confused, they'll not know what's going on, they'll be frightened, and they need a lot of professional interaction and environments that help them to come to terms with what is happening, in addition to the right medical treatments for the particular problem that they have. And so we're going to see situations of acute onset of schizophrenia, manic phase of a bipolar disorder. Very commonly these days, not even really clear what it is, just substance abuse-related psychotic symptoms that demand an urgent response. While many people don't think about depression as being associated with psychiatric emergencies, in reality, in terms of suicide and completed deaths, of course, severe depression and some forms of depression not only place the person themselves at risk, but may place their family or other people who they're close to. And then there's that whole group of people who are frequently encountered in emergency departments and in other medical settings that frequently self-harm, often do attract personality disorder diagnoses over time, that I'd like to emphasise can be appropriately managed both for their disorder and also to reduce the chance that they'll represent on future occasions for emergency or psychiatric care.
So don't just slough the person with personality
No, there's a great temptation to go, okay, they're not acutely psychotic, they appear to have a personality disorder, they've done this many times before, let's move them out of the system as quickly as possible. And an opportunity is often missed for, in fact, productive interventions.
But it'd be fair to say that most self-harmers are people who are depressed, isn't it?
In reality, people with self-harm are going to have significant diagnoses like depression, anxiety, they may have on top of complicated other issues. And so sometimes we get a little bit too carried away with the self-harm and in a sense that it's under self-control and they should just stop it, as distinct from dealing with the issues that might be contributing to it. And the best chance to deal with that may well be in an emergency department or other general medical settings. A lot of those people have great trouble getting engaged with formal psychiatric services. So there's an issue about using the opportunity to do good for the person individually and also manage their contacts with the health system in the future. I'd like to spend a little bit of time talking about suicide and self-harm because these remain major causes of premature death and ongoing disability in our community. And there's an attempt, again in a lot of hospital settings, to differentiate attempted suicide as not being serious from suicide, which obviously is, and say they're two different schools of activity. It's important to say that attempted suicide predicts later suicide. And people who have attempted suicide, we should be grateful they're still alive and we've got an opportunity to actually look at what is going on. And that actual completed suicide has more to do with age and gender and access to means than actually necessarily intent to kill yourself. So any attempted suicide is an emergency from our point of view and a chance to get involved and perhaps negotiate a better outcome down the track. And in a sense, the Australian healthcare system and the Australian statistics about suicide have been changing over recent times. What we do actually matters. And so if you look at the suicide statistics over the last 10 years in Australia, you see in the early 1990s high rates of suicides in young people and in older persons. If you look at the most recent statistics, you'll see dramatic falls in the 15 to 24-year-old age group at the left-hand side of that graph, and some significant falls in older people where increased treatments for depression appear to be having an effect. But you'll see right in the middle is the 25 to 44-year-old age group where suicides are as high or higher than they were a decade ago. And that's the group of young men, often with alcohol and substance abuse, often with comorbid psychiatric disorders, that we are really struggling to engage with. They don't come to regular services, and they're the ones who are likely to interact with emergency services. And they're a group we really need to make a better effort with. So the emergency contact may be the opportunity with that group to actually make a significant difference, may be our only opportunity to really get involved.
So that's that group of poorly educated, single, angry
Well, I was just
men.
going to say men,
Yeah.
but on the whole, they don't learn quickly and they don't engage with the system. I mean, they're not natural users of the healthcare system, and therefore they may only present in acute situations. Now, there's a tendency for, of course, the rest of us to feel most threatened by men in that age group who are intoxicated, who are difficult, who may have lashed out, and to again see that as a big problem. I'm just trying to emphasise that, in fact, their chance of being dead from their psychiatric disorder and their substance abuse remains high, and we as a health system have not sufficiently engaged with that group. So again, that kind of emergency presentation, although perhaps very difficult for the clinical staff and originally involved, may give us our best opportunity of changing the long-term outcome for those people. A lot of the people that we see haven't rushed to see us. They think that actually treatments are harmful. The Australian community still thinks that a lot of treatments for depression, for example, are harmful on an ongoing basis. So we see surveys constantly looking at the belief that antidepressants are harmful and our treatments are harmful. A lot of people are afraid of what we're going to do. So we can get into a situation where our staff are afraid of the patients are actually afraid of us and what we might do in the situation. And understanding that to some degree, understanding what people expect from the system and being afraid of what might actually happen if they're diagnosed as having a psychiatric disorder, if they present for care, contributes to the situation. When you see someone who's actually in these situations, one needs to take the time to look at some of the important causes. And while for general psychiatric disorder we discuss things like genetics and past experiences and current life situations, in the emergency situation, two of these factors just really need to be constantly highlighted. One's the effect of acute intoxication, that a lot of the behaviour that you see may not be the long-term behaviour of that person. It may be significantly changed by their level of intoxication or withdrawal. And the other is taking the time to observe whether they might have another medical factor, particularly a neurological or brain-related factor that is influencing their behaviour. And often in interaction with the person, observation of their behaviour, a conversation, one's trying to sort out in a hurry where there might not be a brain-related factor contributing to the behaviour that needs to be dealt with urgently. We tend to get very moralistic in medicine about what people do when they're psychiatrically distressed. And in surveys done in the Australian community, if you ask people, well, what would you do if you had a psychiatric disorder, they all say, of course, I'd get out more, I'd get counselling, I'd talk to my family and friends, and I'd do all these things which are good for my health. The reality, of course, is when we all get distressed, we don't do that at all. The first thing we do is we get intoxicated. That's what we all do on an ongoing basis. That's normal behaviour. And if you think about it, how you might end up in this kind of situation yourself, it may well be that you were distressed and then you were drinking and then something else went bad, and you would present for care in an intoxicated state, and you wouldn't necessarily want people to think you were like that all the time. And so I really want to emphasise that this is the common way that people in distress in Australia attempt to cope with the situation, and we need to recognise that and respond in an appropriate way. If we look at the relationship between psychological distress and all the substances we have available to us, nicotine, alcohol, binge drinking, cannabis, what you see is higher levels of distress go with higher levels of use of all of those substances. So rather than the exception, it's the rule. That's what we all do when we get distressed, and it will influence and colour our acute presentations, but we need to be careful as health professionals that we respond in an appropriate way. On the whole, if we're able to provide treatments, if we can engage with people, then we have very good evidence that that produces long-term gains. And so in Australia, we've seen reductions in suicide associated with increased provision of treatments. So seizing the opportunity to provide effective treatments, trying to engage the person despite the difficulty around the emergency situation, should be a particular medical goal. And I want to emphasise really the value of treatments, because treatments get a bit of a bashing on a regular basis, and particularly treatments of young people in Australia. Just to look at one of the big studies of the treatments of depression, run independent of the pharmaceutical industry by the National Institutes of Mental Health, who looked at suicidal adolescents being treated for depression. And basically, if you look at the outcomes of all the treatments that were provided in those graphs, which you look at psychological treatments combined with or on their own, or combined with antidepressant treatments or on their own, the big factor was just getting treatment. Any of the treatments that we provide make a big difference, not only to things like depression in the far left graph, but to suicidal behaviour in the far right graph. So the big message here is, if we can engage, if we can grab the opportunity, we probably make a really big difference to the long-term outcome. Just as we heard with Jonathan, if someone can get through those difficult early phases, often they can look forward to a much brighter future.
Thanks, Ian. Of course, Chris, physical illness is often a hidden issue here.
Sure, well, sure, absolutely, but also, also it seems to me a lot of the presentations are people seeking help through medical complaints as well, not necessarily feeling comfortable discussing issues of their mental health or their comfort.
So they can be in crisis, the old Michael Ballant thing, the ticket of entry to the GP, and they can be in crisis, but they've come in with a physical complaint.
Yeah, I think that's common.
John Raftos, could you talk about how you approach this in the ED?
Thanks, Norman. Look, I think that the first thing that I'd say is that we probably do two things in the emergency department. The first thing that we do is minimise the risk, and I think that's an extremely important component when these people present acutely distressed. And so often what we do is just provide them with a safe situation for 12 or 24 or 48 hours until the crisis settles, or we can give them some treatment. And the second thing that we do, which is just as important, is to put them into an ongoing care situation. So we can a patient can come to harm in both ways. I think that if we don't properly assess their risk and we don't manage the risk appropriately, then the patient can come to harm. Similarly, once we guide them through their acute distress, if we don't put them in touch with ongoing services, then they can also come to harm. But I'm going to speak mainly about risk minimisation in the first 24 hours of the presentation tonight. When we look at risks, there are a couple of obvious risks. The first one is physical harm to the patient, the possibility that the patient might suicide, or that they might come to harm in some other way by accident when they're out of control. Secondly, that the patient may harm someone else. They're the obvious risks. We need to look a little bit further than that. We need to look at harm to reputation. Someone who's in a distressed state, possibly intoxicated, can do a lot of harm to their family, their social standing. And we need to look also, I think, at the neglect, homelessness, hunger, destitution that goes along with a lot of mental health issues. And we need to try and minimise those things if we can, because we're really here to be caring for people. So let's take a quick look at the common presentations that we see in the emergency department. And these are fairly motherhood statements. I think most people know that we see a lot of acutely psychotic patients. It's difficult, as Ian said, to differentiate between those that are drug-induced and those which are purely mental illness. Most of our patients, probably more than 50% who present in acute crisis, are intoxicated in some way, with alcohol, with amphetamines, with cocaine, or with a combination of those drugs, and with marijuana. And it's often difficult to make an assessment of the exact problem when the patient presents. Depression, especially out of hours, is a significant problem. Patients come to a crisis, they find no one to talk to, they come to the hospital. Mania, parasuicide and personality disorder. But I think we shouldn't overemphasise the diagnoses in this discussion, because the diagnoses probably aren't as important as the fact that the patient is in crisis and at risk of coming to harm if we don't do something. So what we're more about is determining that risk of harm and how we're going to minimise it, rather than make a diagnosis. And diagnosis can be difficult in this circumstance. So how are we going to do that? I think the most important thing to realise is that these illnesses that we're talking about are medical illnesses, and that we should approach them in exactly the same way as we approach other illnesses. So the first point, I think, is that these patients are ill, and we should approach them with empathy, whether they've been in the emergency department 10 times in the past week or once. It really shouldn't matter. They should still get the same empathic approach, and we should approach their diagnosis and their interview in a systematic way. So the way that we get the information that we want is through the interview. What do we want to know when we interview a patient like this? We want to have a reasonable idea of the diagnosis, but as I said at the start, and I think as Ian said, the diagnosis isn't particularly important. The most important thing, I think, is to assess the risk of harm. We want to know if these people are going to hurt themselves or hurt somebody else. We want to find out whether this is in fact a delirium, a presentation of a physical illness. So it's important that even though only perhaps 5 or 10% of these patients will have a physical illness, we detect that. And we want to look at their level of social functioning, see what support they have in the community, whether they're at risk because of their social standing. And then we want to formulate a treatment plan fairly quickly after they've come to hospital. So how are we going to do that? The interview is about establishing rapport with the patient so that we can get the information that we need to do the things that we've talked about. And the most important aspect of dealing with any patient is to show that you care about what's happening to them, to be empathic, to be calm, and certainly not to be confrontational or to suggest that they can in some way control their illness, which of course these people can't. That's why they're with us. So I'm going to choose an appropriate setting for the interview, and I'm going to sit down with the patient, and I think that I'm going to establish rapport by dealing with things that aren't going to cause them a great deal of distress first. So I might start talking to them about their past health, about where they live, about what sort of work they might do. Then we might move on to their family health, as we would in any medical interview, perhaps their past psychiatric health. We need to talk about substance use, we need to talk about alcohol and cigarettes, and we need to talk about illicit drug use. We need to talk about any forensic history that they might have. And then, once we've established a rapport by talking about fairly non-threatening subjects, then we may start to talk about the problem that's brought them to hospital. I think it's probably better to be inclusive when you're talking to the patient, so I think it's probably better to ask questions like, what do you hope to achieve tonight? What can we do to help you? What is it that we can do to ease your distress? What symptoms have you had? Why are you distressed tonight? And in that way we can get a reasonable idea of what's happening to the patient. We need to know the social context as well. We need to know where they're living, whether they're living in a house, whether they're living on the streets, what social supports they have, whether they have a supportive family, whether they have supportive people around them. We need to then look at the physical aspects briefly, but it's important to do so. So we need to look at their vital signs, need to look at their heart rate. If they're tachycardic, it may well be that they have an underlying physical illness causing their presentation. We need to do a relevant physical examination, but obviously it's not going to be particularly detailed. And then we need to sit back and we need to do a formal risk assessment once we've completed the interview. And the risk assessment will take a standardised form. A lot of people use the SAD person scale, which someone will talk about a little bit later. But we need to make an assessment on known data about which people are likely to come to harm. So we know that young men are at risk. We know that intoxicated patients are at significant risk of coming to harm no matter what the drug might be. We know that patients with poor social support or who come from a marginalised group are at substantially increased risk from harm, and we need to take all these factors into account. And then I think it's very important to get a corroborative history. The patients in crisis, they're not going to give you a particularly accurate version of what's been happening, and so it's important to corroborate what they've said with an appropriate resource, and we might speak to the family, we might speak to the general practitioner, we might speak to other mental health services that they've been in contact with recently. I think if you neglect the corroborative history, you can come to significant harm. So that's a time-consuming but important part of the interview. Briefly talk about safety in the interview, because whilst the patient's safety is of paramount importance, our safety is of importance as well. And how we conduct the interview, to a degree, defines how much information we're going to get from the patient. So we need to have them in a safe area, a room which is quietly lit with quiet colours. We need not too much furniture and nothing that can be used as a weapon. We need to have privacy. Obviously, if the patient's agitated, the appropriate thing to do is to have some security or police presence, but the police and security should be outside the room and the patient shouldn't feel threatened. And we probably need to check the patient for weapons, or we need to get the security people to check patient for weapons before we interview them. We need to think of our own safety and have an egress route if anything does go wrong. Our manner is very important. You need to be empathic, you need to be calm and non-judgmental.
And presumably not patronising as well, which is presumably easy to drift into. You're smiling, Ernest.
It can be very easy, but I find that just a normal conversational interview, treating the patient as any other person, is generally effective. You know, people will appreciate it if you're concerned about what's happening with them, but not judgmental or anything else. Now, so that needs a quiet, calm tone. It needs the interviewer to be reasonably relaxed, and that comes from experience. It's not something that you can do particularly easily. And the other thing that we need to do is avoid confronting these patients. It's very easy to stir up a patient who's agitated, much more difficult to calm them, but that's the appropriate approach. And we should avoid deception too. We shouldn't promise them things that we can't provide. Now, we need to talk very briefly then about what we're going to do with these people. If we perceive that there's a risk, we're duty bound to keep the patient in hospital until that risk is passed. That may be a period of 12, 24 hours, and we're duty bound to use the Mental Health Act to do that. I'm a great advocate of using the Mental Health Act. Whenever you think a patient needs to stay in hospital, then it should be clear to everyone involved that the patient needs to be detained if they want to leave, and that you've invoked Schedule 2 of the Mental Health Act. I think that saying that I'll schedule the patient if they want to leave is open to all sorts of risk. There shouldn't be any doubt in anyone's mind that the patient needs to stay for their own safety, and that the Mental Health Act has been invoked and will be enforced if they want to leave.
And Ernest, does that work the same way in Queensland too?
Mental Health Act is a little bit different in Queensland, and unfortunately the Mental Health Act has been structured to address metropolitan clients rather than rural and remote clients. So we run into all sorts of difficulties outside of metropolitan areas.
We'll come back to that in a moment. What about restraint?
Well, I think that it's always best to to talk a patient down and to get them to agree to stay in hospital
Sometimes that doesn't work.
of their own will. Sometimes that doesn't work, and for everybody's safety, it's then necessary to diffuse the situation. So we need to physically restrain the patient for a short period of time whilst using chemical restraint. And chemical restraint is obviously the best way to...
Because physical restraint can be quite risky.
Over the last few years, we've realised that that physically restraining people results in sudden death fairly frequently. There are incidences in Sydney and in Australia in the last 2 or 3 years where young people who've been physically restrained by police or by security officers have died of hog-tie syndrome or something similar.
So what do you give when you're chemically restraining them? What's the advice?
Well, I think the advice that I'd give is that benzodiazepines are the drug of choice, and they're a very safe drug. So the best way to give benzodiazepines is intravenously. That means that you have to have confidence in putting an intravenous cannula, and you have to have adequate personnel to be able to restrain the patient. So by choice, I'd do that intravenously. I'd put in an intravenous cannula and I'd use diazepam because it's longer acting than midazolam. I'd use an adequate dose of diazepam. In the first instance, in a fit young person, that's going to be 5 to 10 milligrams, probably more likely to be 10 milligrams.
And if that doesn't work?
I'd repeat that.
How often and by what space of time?
Probably in the one sequence until the patient was adequately sedated. So I'd probably give 5 to 10 milligrams to start with. If the patient was still agitated, I'd give another 5 to 10 after probably 5 minutes until the patient was adequately sedated.
And if it's intramuscular, how long would you wait to see the effect?
Intramuscularly, we can't use diazepam because it's irritant, but we'll use midazolam because it's okay to give intramuscularly. And the dose is the same, and the onset of action is pretty much the same. And so I'd be using anything up to 50 or 60 milligrams of diazepam or midazolam.
And you just go up until they fall asleep?
You go up until they fall asleep. And they're extremely safe drugs in that group of young people. I'd advise a bit of caution over the age of 60, but under 60 in a previously fit patient, you're very unlikely to cause harm using those drugs.
Chris?
Well, look, I think it'd be worth just discussing the real practicalities of the issues, either in a doctor's surgery or an emergency department, because I think for me the challenge is always, I've made a judgment that this is a patient that will need restraint, but at that stage they're walking towards the door. I've often got limited number of staff in the emergency department. The police are not usually on site, and I always find this situation really, really challenging. And you know, having 5 people around to restrain is a luxury that I don't always have. And it's just this really awkward balancing act of what you can do that is safe, and it is a challenge. I mean, as soon as these people are out the door, you feel like you've lost control of the situation. But it is a very risky situation. So I guess it's great to hear the advice that that we've really got to manage this risk of intoxication. I mean, that's really, really important advice for me to hear. And I guess it's great to hear that it's good to have 5 people on hand, and it's great for us to immediately go...
Well, what's been your experience, Fiona? You're also in a rural area.
I have to say I agree with Chris. I think it's a real issue with resources, and, you know, trying to contain someone who is intoxicated and suicidal is probably any GP's worst nightmare in a rural setting. You know, medication and the value of the therapeutic relationship I think shouldn't be underestimated, but before we jump the gun and start looking at IV medication, I think we should be attempting at least to offer oral medication wherever possible, and building on that relationship and developing that. If it all goes pear-shaped, I guess sometimes it's situations where the patient does leave the surgery and you need to then call on your resources in the community to attempt to bring them to hospital.
Ian?
Well, I think it's a really important set of issues, because the relationship issue works with a small number of people, and offering oral medication, using the prior relationship with the GP, using other family members to attempt to persuade and engage, so that even if the person's confused, they may listen to people they know. But if the situation gets right out of hand, then I think what you're saying is, you know, it's not the situation for a nurse in a surgery and a doctor and a receptionist to try and tackle, you know, a young aggressive man who's intoxicated and psychotic. So I think at times we've got to sort out our roles where we can do useful things based on our medical background and our prior relationship from those situations in which we really require the assistance of other services. So that, and that reduces the chance that actually the person themselves gets hurt along with the staff.
So what do you do when the person walks out of the surgery and you haven't got anybody else there to help you?
Well, I think that's where you do call on the police, you do call on other emergency services, and I think the point has been emphasised. It's not a situation where you get 3 people to go and tackle one aggressive young man who's intoxicated and psychotic. Otherwise, everybody's going to get hurt at the end of the day. So I think when you've got the person, it's those interpersonal skills, it may be the use of family, it may be the use of other people who know the person, might be able to persuade the person to take oral medication, to accompany the person to hospital, and typically a person they know rather than a person they'd never met before, a person who suddenly turns up in a uniform or turns up, you know, with a clear kind of threat. If you're going to have to use physical restraint, then it's an issue of numbers. You know, in all of these situations, you're far less likely to have actual physical harm to the patient or to the staff when the physical numbers are strongly in your favour.
Just a couple of questions of relevance to this discussion. Tim O'Brien from New South Wales GP asks, if you miss, you know, if you don't detect the acute situation correctly or don't manage it properly, does it make later treatment harder?
Well, there is an issue with acute psychosis that if you delay the onset of treatment, that it's typically harder to treat. Now, that's probably because by the time you see the person, then they're using other drugs and alcohol, so they've started to treat themselves, and it may delay the effectiveness of treatment. But usually the first time you get to actually deliver a treatment is your best opportunity to get the best recovery. So it's the first episode of care and doing that well that probably gives us the best overall chance of getting a good outcome.
And there's another question from North Queensland, from Marissa Pillars, asking, well, in that acute situation with psychosis, what's the right treatment for the psychosis? Is it an atypical? She's commenting that she still sees people giving typical antipsychotics with all the side effects.
Well, I think John emphasised one really important issue which I'd like to re-emphasise. The tradition has been for psychosis to give people lots of antipsychotics, and particularly typical antipsychotics during the acute phase, which often doesn't sedate them.
Things like haloperidol.
Yeah, and they may well get akathisia, motor restlessness or acute dystonia and feel terrible. So often if you talk to young people in particular who've been treated that way, they say it's awful. They give them midazolam, they can't remember what happened. They give them diazepam, they went to sleep, and the whole thing was far less traumatic. So in the acute phase, if sedation is the goal, benzodiazepines largely, and then certainly uses of low doses of antipsychotics, probably preferably the newer atypical agents rather than typicals. But I think everyone's grown up in an era of emergency medicine and anaesthetics where there was something magical about typical antipsychotics. In truth, they just created a lot of trouble.
I think if I could say something, in the old days we used to use chlorpromazine, which was a very dangerous drug. Certainly wouldn't be using that anymore. All of the antipsychotics have a risk. Haloperidol has a risk, so we'd use that minimally. And I think that the benzodiazepines are going to work in the first 24 hours, and they may well have a substantial effect into the first little while. If we're going to add an antipsychotic, we'd much rather these days add an oral... one
of the newer ones.
Yeah.
Small dose of olanzapine, small dose of risperidone, and that's all you need to start treating the psychosis.
That's right.
And that's going to be a long-term issue.
Ernest, clearly there are specific situations with Aboriginal people and Torres Strait Islanders, and obviously many acute situations to have to deal with.
That's right. I'd agree with all of the points that have been made so far, and might comment on some of those issues in terms of acute management of psychotic disorders in a moment. But I think one of the issues that I would like to emphasise is the importance of understanding context in being prepared to address emergencies in Indigenous communities. And to take one example of that, thinking about the demographic context and specifically the population distribution in Indigenous communities, this shows the population distribution in the wider society, and as we can see, there's a relatively small number of children in the wider Australian population to adults generally, and a significant number of surviving elderly. If we superimpose on that the Indigenous population, we see something very different that has implications for the sorts of mental health issues that we see and for the crises that present. First of all, we see very few crises in elderly Indigenous people for the simple reason that most of them have passed away. However, it's worth noting that when you actually look at surviving elderly in the Indigenous population, the rate of cognitive decline and of other mental health problems is actually greater. At the other end of the spectrum, we have a far greater burden of young people to caring adults. The youth dependency ratio is much greater. That has a number of implications. There are a variety of problems that impact youth that we don't see because of this, because of the stresses of having so many children in the population and because of the failure of systems like the education system. We're not picking things up like attention deficit disorder, etc. But we also have a greater burden of young people and the problems that they bring with them. Having a high youth dependency ratio is also associated with a number of problems in their own right, specifically problems of violence and problems of self-harm. And that, I think, broadly reflects the stress of these communities. And it's probably worth noting that I think there is a rather romanticised image of Indigenous communities as stress-free environments. In fact, they're very far from that, and the data that we have show that the numbers of stressful events are greater, the experienced stress is greater, and there is now data looking at catecholamines and corticosteroids and showing much higher levels in Indigenous populations than in the wider population, and also that these levels appear to vary in concert with the periodicity of the welfare system. So these are communities that are often buffeted by waves of stress. In terms of mental health emergencies and how we conceptualise them, you might use an age model, because there are emergencies at every age. Prenatally, I would say that being aware of trauma or heavy alcohol use by a woman constitutes an emergency. Amongst infants and toddlers, physical abuse, amongst children, sexual abuse. Young people, the sorts of things that we're talking about here, actual and threatened self-harm and psychosis. Among adults, intoxication, withdrawal and psychosis, and delirium. However, the common emergencies that we see are attempted and threatened self-harm, acute psychosis, and psychotic relapse. Interestingly, the DTs, the next slide is the common emergencies. Delirium tremens is actually not very common in Indigenous communities that I work in. And then we have intoxication with violence and a range of less common emergencies. I'll mention briefly psychotic disorders and show some of the data in relation to the commonality of these disorders compared to the wider community, but won't expand on this because others will talk about this. The point I'd make is that, at least in terms of hospital admissions for this data period, 98-99, mental disorders due to psychoactive substances and schizophrenia for both males and females varied from 2 to more than 4 times as common. So with that kind of gross index of morbidity, we can see that these are very common presentations. What I would like to talk about is suicide and show some data from Queensland to identify some similarities and differences to the wider population. In terms of suicide in Queensland, for the wider population, 20% of completed suicides are female, 80% are male. Comparing that to the Indigenous population, we see the situation's very, very similar. What is different is when we start to explore the age distribution of suicide. For Queensland as a whole, some 42% of completed suicides are under 34 and 80% less than age 54. If we compare that to the Indigenous population, we can see that the proportion of young people is significantly greater. 83% are under age 34 and nearly all, 97%, are less than age 54. So a significant difference is more youthful age amongst those people who complete suicide.
And that's independent of the demographic bulge that you just described earlier anyway?
Yes.
The fact that there aren't many people over 54?
Yeah. If we look at the means of suicide, this is a particularly important issue. For Queensland as a whole, 55% of suicides result from highly lethal means, that is firearms and hanging. These actually have roughly the same lethality in terms of the proportion of people who die as a result of attempts. If we look at Indigenous populations, we see a startling difference, that 95% of deaths are due to hanging or firearms. That is, nearly all Indigenous deaths are due to hanging, and 99% are due to either hanging or firearms.
So your point here is that there isn't much latitude in the means?
Absolutely not. Highly lethal means being used, and I don't think that it's commonly understood how lethal these means are by Indigenous people, or by people generally in the wider Australian society, because I think there's a sense that there is something a little bit iffy about hanging, whereas we now have a large number of deaths where it's really open to question whether the person's intent was to die. People were generally very intoxicated. A death in a community last Friday, a woman very intoxicated, found squatting on the ground with a hose around her neck, who had fallen forward on the hose. Now, whether she had thought this through, or whether this was an impulsive event which had gone tragically wrong, is hard to tell. So in terms of thinking about Indigenous self-harm, attempts are equally distributed by sex, but completed suicides are far more common amongst young males. Young males are 3.5 times more likely to die by suicide than non-Indigenous Queenslanders, and young women 2 times as likely. In terms of immediate features, intoxication is very common. Binge drinking associated with self-harm is very frequent. A confrontation often precedes the act. This may be something which appears on the surface to be extremely trivial. These are often occurring in people who have a history of impulsivity. Frequently in Queensland we see clustering over a period of time in particular communities, and modelling is an issue.
So essentially that's copycatting, is it?
Well, whether you would want to call it, I think that there is an element of copycatting, but I think that it relates to what I would call a level of community risk, that in thinking about risk in Indigenous communities...
So this is a community at risk rather than...
That's right. You know, I can give you a very brief example. We had a suicide and some further attempts in a particular community recently. This is a community which isn't subject to the prohibitions on alcohol in other communities around Cape York. As a consequence of that, a lot of people who wish to drink have moved into town. What they've done is brought the tensions and anxieties and pressures to town that would otherwise be in their communities of residence. That's really created a level of tension in the community as a whole and lowered the threshold. So we're talking about a level of stress that's impacting and a level of risk that's impacting the community as a whole. But these are patterns that are changing over time. If we look at the period from the 1970s to the present, we see that there was a period through the early 60s to the mid-70s of considerable turmoil in Indigenous Australia as people entered the cash economy. Access to alcohol was provided, people were dislocated. And in that context, we saw a dramatic increase in death from misadventure, from accidents, from homicide, from motor vehicle accidents. This was really the behaviour of young adults who had encountered the social change as young adults and whose disinhibition is reflected in that mortality. Suicide didn't increase until the late 1980s and early 1990s. And that occurred largely in the aftermath of the Royal Commission into Aboriginal Deaths in Custody, and it involved teenagers and young adults primarily. Those people are the children of that first group, and they are the first generation to have grown up in environments of normative instability. What we see now in the last 4 or 5 years is a very troubling development, and that is we now have a significant number, at least in Queensland, of children who've died by suicide. These are children as young as 9. We had 4 12 and 13-year-olds who died in North Queensland within a few months, a year and a half ago. Looking at the common features amongst these children, one of them is that they've all been exposed to self-harm. That suicide in Indigenous communities is highly visible. It's a public event. It's not somebody who has gone and taken a motel out somewhere by the airstrip, by the airport. It is a public event and lots of people are exposed, and that has implications for the way in which we deal with these circumstances in Indigenous communities. So in assessing the immediate risk of self-harm, we have to think about lots of issues. We've got to think about history, we've got to think about circumstances, and particularly in Indigenous settings, I think we have to be attuned to what the local resources are. What do we know that's there that we can call upon? Ultimately, assessing immediate risk is a judgment. Risk is never eliminated, and there are lots of different tools. Every district will have its own screening tool, and one of those is SAD persons, which I'll mention, but they really are there to facilitate a judgment. We can never rest complacent on the basis of a score. And at least with Indigenous people, I think probably also with people generally, there are two issues that preclude being complacent. The first is having a person who's intoxicated and is going to continue to drink. And the second is a patient who is alone or is going to be with people whose judgment we can't rely on. The SAD Persons Assessment Guide simply addresses key factors: sex, age, depression, and I might make the point that depression is really not as common a feature of Indigenous self-harm as it is in the wider population, accepting the points that were made earlier about the impulsivity and circumstances surrounding particular instances of risk. P is previous attempt, ethanol, rational thought, social network, organised plan, no spouse, and if a person has a comorbid sickness. All of these are simply aids to making a judgment. In terms of issues in response to self-harm in Indigenous communities, I think we're well advised to use the same principles of mental health first aid as apply to the wider society, listening non-judgmentally, giving reassurance, encouraging help, encouraging self-help. These issues were covered earlier. I think we're advised to be aware of informed listening. By this I mean that if we're going to work in Indigenous communities, we should at least be attuned to the circumstances and issues of those particular communities. That doesn't mean becoming an ethnographer or an anthropologist, but having a broad understanding of local matters. We need to be attuned to local informants and gather collateral history, and we have data that demonstrates that assessments of mental health outcomes with and without an informant, when made by a non-Indigenous person, are quite different. And indeed, the assessments made with an Indigenous informant tend to show higher levels of distress and disorder. So we're often underestimating when we don't call on informants. A trivial precipitant is not the same as a trivial risk in Indigenous community, and assurance can never guarantee safety. And I think we're advised...
So what do you mean by that?
Well, that somebody insists that they're going to be okay, or that relatives or others in whom we don't have confidence insists that they're going to be okay.
My uncle will look after me.
Absolutely. And we need those other informants who can let us know not only about the index case here, but about those other people who are going to populate that scene over the next 24 hours. And address arousal, time, tea, and perhaps tranquilizing. Given that many people come in intoxicated, the longer we take in our assessment and in our management, the more time for them to become less intoxicated. The take-home messages are that there are differences to the mainstream in terms of the age distribution, in terms of means. There are changing patterns of vulnerability in time, and I want to emphasise the particular risk of children. That risk is something that we should consider not just in terms of individuals, but in terms of the community. And we should think not just of risk of suicide itself, but the people that we see presenting are leading lifestyles at risk. They're equally at risk of death from misadventure and other kinds of harm. Precipitants may well be trivial.
Such as?
Confrontation with a parent over money, a girlfriend who's walked out. It may be what seems to everybody to be a give it a go threat, give me $20 or else. And unfortunately we've seen tragedies that have followed that. We should be aware of the importance of informants and collateral information. There are critical elements in the short term, preventing substance use and ensuring immediate supervision. always take note of the cautionary principle, and I agree that we should be ready to evacuate if we have to do that, and we have to be assertive with follow-up.
Thanks very much, Ernest. Fiona, does that tie in with your experience in New South Wales dealing with Aboriginal community?
Most certainly. I think, you know, definitely with looking at the means being more lethal than just the average population, and also the high use of alcohol with the Aboriginal population then just puts them more at risk. And it doesn't take much, as Ernest says, for it to be a precipitant to tip someone over the edge.
Now, you're developing a retrieval system around your hospital.
We're in the process of slowly developing a retrieval system. Yes, we're looking at having nurses and transport driver travel out to smaller sites within a 2-hour radius of Tamworth-based hospital, and assisting the local communities and the smaller emergency departments out there in managing those who are of the Indigenous population, and also people who have mental health problems in general.
So Ernest, what's your view of that sort of retrieval system for Aboriginal communities? Is it just a matter of judgment whether the person is best treated in situ or plucked out for safety?
It depends entirely on what the context of that community is. I mean, the communities that I work in don't have medical officer coverage, and we actually don't have 24-hour nursing coverage, so the issues are limited. I'm reluctant to rush in and evacuate people, but I think we've just always got to have that up our sleeve. All of our evacuations are done through the Royal Flying Doctor Service. So it's not a minor issue to summon a plane and get people out for evacuation.
Chris, do you have a view?
Look, I don't have the same experience in that sort of a remote environment. I just appreciate the challenges of having to call a plane for an evacuation. Sounds very challenging.
There's a question here which perhaps Fiona you might want to answer. What advice would you offer a carer who lives a significant distance from, you know, the hospital or the clinic, but they've got to travel with somebody who's having an acute psychosis, acute psychotic episode? What advice would you give them?
I guess you'd have to look at whether or not having a carer transport someone who's actually acutely psychotic is whether it's appropriate. Certainly, we'd probably look at other means if someone's experiencing an acute psychosis, to look at perhaps sedation and then an ambulance, and with a nurse backing them up. There's certainly instances where carers are considered the first option for transport, but that would be usually in a less acute situation.
Ernest?
I think that having an informant and a relative go with the patient is critical in the communities that I work with, and we attempt to do that with every evacuation, not only because it facilitates the...
But this isn't an evacuation, this is somebody who's jumping into the car and driving in. Yeah. What would you suggest?
Well, yeah, well, I could certainly comment that, like, in my emergency department, in my practice, I mean, that's how people routinely present. They're almost universally brought in by a family member rather than through ambulances or professional assistance. It's
and
really unusual.
Presumably, John, it's just that stay calm, don't confront, just matter of fact and get in.
Yeah, I think...
we're in evidence-free territory here.
Yeah, we are in evidence-free territory, but I think that the safety issue is important. I think that if it's possible to get an ambulance or a worker to the patient who's acutely psychotic and agitated, then it's much safer to do it that way.
I think it's a general issue with managing risk in these kind of situations where you get more than one person. So if one person's driving the car, if you've got one or two others, or if you can get some other relatives to come. So you don't really be driving the car yourself with someone who's psychotic and by nature unpredictable in their responses. So hopefully not on your own.
And there's a question here from Dr. Johnson in Cloncurry. What's the commonest psychiatric emergency? There's several questions here.
Well, the commonest one really has got to do with suicide. I mean, it's just whether, you know, most professions don't call that an emergency, but actually from the patient point of view, that's the situation where most people end up dead. From a health service point of view, most emergencies are tied up in the combination of substance and psychosis.
Right, so sort of a mixture of high prevalence and low prevalence in a sense.
Yeah, and so I think, you know, we define emergency by threat to us and by havoc on our emergency and healthcare settings, and that's definitely intoxication increasingly on top of pre-existing mental health problems.
And alcohol still the commonest substance?
By far.
So it disputes everything else. That was the other question, Dr. Johnson. And the other question he's got is parasuicide regarded as a psychiatric emergency?
Absolutely, and I think that's a really important issue. I mean, this parasuicide versus suicide, for all the reasons that Ernest was just emphasising, you know, there's a notion that parasuicide is not serious, not an emergency. You know, it's really access to means in different communities that might determine the outcome, not the intent the person actually had. So
let's go to, we've got some case studies here, so let's go to our first case study. David is age 20. He's brought to his general practitioner by his mother, who's concerned about his recent behaviour. Over the preceding 3 months, he's become increasingly erratic. He's sent emails to his employers accusing them of following him and spying on him. And his mother says he's fascinated by the TV and his computer and spends hours sitting staring at them both. Your patient, Dr. Mitchell.
Well, I mean, we've obviously identified some significant risks, and particularly some of the paranoid features of that sort of discussion. Well,
he tells you he's actually under instructions as a secret agent from President Bush.
Yeah, so I mean, there's some risks. There's some risks there that need to be addressed.
It's not necessarily irrational, actually.
Well, there's some risks there that really clearly need to be addressed, and this young man needs to be in a safe environment, and there's going to be a fair bit of history that's going to need to be collected to determine how safe the environment at home is, how much support he's likely to have at home, and whether it may not be more appropriate, in fact, to stabilise this young man in a hospital.
What do you think, Fiona?
Well, it's fairly evident he's psychotic from the symptoms he's describing, and I think to look at a plan before it gets to this stage is really important. If you've got some inkling that you have a young person in your surgery who is unwell, then perhaps you need to look at some strategies to get yourself some backup pretty quickly if you suspect that they may leave your surgery.
Does this qualify as a psychiatric emergency, David? Ian?
Yeah, I think it does. Any acutely psychotic young person, there's unpredictability and there's certainly the chance of considerable risk arising. So one needs to know a lot more about the situation. The psychosis you might take as a given, but his degree of drug use, the capacity of the family to cope, the actual social context in which he's occurring are the things you really need to find out about urgently to decide whether home-based treatment is possible, and also obviously the capacity of local services. Is home-based treatment possible? Or in reality, for example, there's a lot of drug use, if there's a lot of family chaos, that really the whole situation would be simpler and safer in a hospital environment.
So, Chris, in your situation, you're actually probably for a rural area pretty well provided for professionally. What would you be doing?
Well, we've got some fantastic services in terms of the acute care services, and it may in fact be possible using some frequent visits with a family that's able to provide the sort of support that's needed to complete that process. But often I find the families a fairly chaotic environment anyway. They're obviously going to be increasingly stressed over the last 3 months, and their capacity to support somebody in what's going to be a very challenging time would mean that I'd have a fairly low index of considering inpatient care.
Defusing the family situation,
yeah,
so the child can move on, well, kid can move on. Any comment, John?
No, I think that there just needs to be a very thorough risk assessment, and the fact that they presented suggests that the family may have come to the end of its ability to care for this young man. So I'd be tempted to, especially when you look at the paranoid elements, to be putting him in a place where he's absolutely safe for a few days until we can improve things.
And you really want to, Ian, capture this, because this would be considered early psychosis, and therefore you could change the whole course of his illness.
Well, I think that's the critical thing, Norman, is whatever you do, you want to make sure treatment happens on this occasion. So, you know, if it can be home-based, if it can't, then actually you seize the opportunity. And that means working very productively with the family as well as the young man. The young man himself is likely to be confused and distracted, but making sure you're working with the family if they find it easier to deal in the hospital environment, if it has been emerging over a long time, if they feel out of control, supporting them to make the best decisions and hopefully seeing the treatment through on this occasion. What we tend to end up with is multiple presentations, chaotic care during this phase, and that ends up hurting everybody.
Let's go to another case study. You're working in a remote community as the primary care physician. The local health worker, who's called Josie, tells you about her concern about her niece Simone, who's 14, and Josie's raised her since she was aged 6. Simone's had a pretty hard start to life. Her mother had a substance-affected life, and Simone was admitted to hospital with failure to thrive on several occasions. She's been difficult, emotionally labile, and really hasn't been in the education system very much at all. But her behaviour has changed over the last couple of months. Her auntie suspects that she's been using marijuana with the other kids. Simone was witness to the aftermath of a suicide in the community 5 months previously. And last night she demanded money from her auntie, and when this was not forthcoming, she became very angry. She threatened to hang herself, and Josie later had to wrestle an electric cord from her hands. She was taken to the clinic where a sedative was prescribed after a consultation with the on-call doctor in a nearby town. She slept through the night, but before the auntie awoke, Josie awoke, Simone had disappeared. You're a patient, Chris.
Well, I'm really glad I had to listen to this talk tonight, because I feel much better armed to identify this is a really, really high-risk situation. And thanks to Ernest, I've actually got a few hints as to where to go from here.
Have you integrated your information for your CME points tonight, Dr. Mitchell?
So certainly having close understanding of what's going on in the community, having some context of people that are likely to be able to assist me in finding where this person has been, and identifying this as a very high risk situation, even though the lethality of the attempted hanging, on first principles, I may not have considered that. I mean, it's after tonight, I'm going to be acting very swiftly.
Yeah. I mean, Ernest, is it too late for this? In your experience with the child's disappeared, is it too late? Are they going to be found dead?
No, it's not too late, but she's got to be found. And I think one needs to draw on the knowledge that we have of this community, the knowledge of who are the key players who we can call on at this time, to be able to actually identify where this girl is and to be the intermediaries. It's not just a matter, I think, of saying, well, the health worker is the person that we're going to utilise here. It may be that we actually have to identify a group of people who are going to help in this. And we have a particular crisis to deal with, and then a lot of other stuff that can be dealt with down the line. This girl has lots of things in the background. We don't know what happened 2 months ago. We're assuming that it's something to do with starting cannabis use, but we shouldn't make those assumptions. She's got so many issues in the background that there is a lot of work to be done down the line. In the short term, we need to be able to identify, provide time, a place, and an individual who might be the appropriate person to engage with her. We need to address arousal, provide security, and
so to
safety.
Play out the typical scenario. So she's found in a distant relative's place down the road or something like that, or whatever. How does this play out a little bit once she's found?
Well, it may be that when she's found, and it might be another relative who finds her, she's quite insistent that she is okay now. She was just angry. I think at this point in time we can't assume that that's the case, and I think that we need to be able to assess that face to face. It may be an issue then of working with an auntie, an uncle, or whoever else is the identified person with responsibility for this girl, to either bring her to the clinic or go to that place and make an assessment. That assessment isn't just of this girl. It's about this girl in a particular social context, in a particular social setting. In trying to identify what the key issues of the moment which have caused this, we're also trying to identify what the range of supports we're going to have in play over the next 24 and 48 hours are, and to be able then to set up a set of issues which may be able to address risk.
And is scheduling part of the story here in the 14-year-old?
Well, we certainly have done that. We don't have a youth facility in Far North Queensland. That means that we are scheduling young people to an adult facility, and we're extremely reluctant to do that. Mm-hmm. The alternative is that this is a person who is going 1,500 kilometres down to Brisbane. That's likewise a significant problem. What we may do, if it's felt that an out-of-community option is appropriate, we would be organising for that girl to, say, come to Cairns along with relatives, and then organise for close follow-up there. And sometimes an out-of-community option is appropriate, because there are a set of social factors that we don't know about that may well be drivers for this particular situation at the moment.
And of course, Ian, if this was a non-Aboriginal kid, you think she was going to be depressed, but in an Aboriginal community, not necessarily so.
Well, depression's not so clear-cut in younger people as well, and I think social context just in non-Indigenous people are equally important here, and so a lot of the issues are going to be similar. But the issue of an early onset anxiety, depressive disorder that might require additional formal treatment, certainly worthy of assessment and consideration.
Let's just quickly go through our final case study. A dishevelled 22-year-old woman presents at the emergency department of a small hospital by taxi. She's actually been dumped at the bus stop following off the Sydney-Melbourne bus, and the bus driver told the taxi driver that she was very agitated, hitting other passengers, whispering to herself, and had defecated in the bus corridor before being removed. You're on tonight, John. She's in the cubicle, she's shouting, she's screaming, she's throwing things around, absolutely hysterical.
Well, the first thing that I'd say is that she's a patient who's ill, who needs care. And I think that one of the problems that we have is that this is a confronting sort of presentation, and that a lot of less experienced staff would be distressed and may not provide empathic care to this woman, but that's how we've got to approach her.
So the sister's handing you the syringe with the diazepam loaded, the midazolam loaded.
Well, it's tempting, isn't it? But look, that wouldn't be my first approach. I think the idea with a patient like this is to establish some rapport with her, to get as much information as we can to find out why she's in this sort of state. But
she's shouting and screaming and throwing things around. What are you doing?
Yeah, look, there's access to the vast majority of people, and I think if you approach a person like this in an empathic way and engage her in a simple conversation, there's a window of opportunity to calm her and to get the information that's necessary to help to look after her. And certainly that would be the first approach that I'd make, and I would think that 8 or 9 times out of 10 that might be a successful, reasonable approach. Then, when I had some information, I might think of giving her, asking her to take something orally to make things more comfortable for her. And then, of course, we'd look. This is a delirium, so we'd look carefully for medical illness, and we'd do a full medical workup, and if that were negative, then we'd start thinking psychiatrically.
How does it work for scheduling in a small hospital?
Well, I was just going to say, this sort of situation virtually never arises unless there's also 2 people with chest pain and a couple of people with broken ankles at the same time. How does the scheduling work? Well, I think this is something that'd be really good to discuss, in fact, because in the institution that I work, the implication of a schedule is that the patient will be moved from the hospital that I'm working in and go to another hospital, and sometimes it seems to me what would be far more appropriate is just to stabilise the situation and just see what happens. And it was interesting discussing a little bit earlier today the sort of role that emergency departments have in the city, that they'll be able to keep a patient under a schedule within the emergency department, which would seem far more appropriate, but doesn't seem to be what the policies in my institution.
So Ian, why is it different in country hospital?
It's not really different, or it shouldn't really be different. I think what everyone's tried to emphasise is the first emphasis should be on safety. And so from a legal point of view, you need to say the person's not able to make decisions for themselves and you intend to treat them under the Mental Health Act. But that's a process. Starts with a particular thing. So you don't have to be in a hurry to move the person instead of providing care. So there's not
an imperative you've got to go to the local gazetted facility?
No. Provide the care, and then if you need to move the person, move them safely. And that will often be after the medical problem has been sorted out or after the other safety issues have been attended to. These kind of presentations are filled with risk. I think we should just remind ourselves of the Cornelia Rao situation. People jump to assumptions. In this sort of assumptions about chronic psychiatric illness, assumptions about the absence of medical illness, assumptions about the harm that's going to be done. And instead of, as John emphasised, taking a little time, getting it sorted, and then really where the person first presents, making sure you get the medical and other issues safely sorted out.
So if your local hospital's got a protocol, shift the patient as soon as you've scheduled, you've got to change that protocol?
Change the protocol. It's the wrong meaning of the Mental Health Act. It is true that the Mental Health Act documents are documents that entitle you to transfer the person to a unit for assessment. But that's a process.
But it's really about patient safety.
Exactly. The first part of the process is the patient being safe to transfer, and that really means medically and psychiatrically dealing with the issue on the spot.
Thank you very much to you all. Fascinating programme. Thank you very much. If you're interested in obtaining more information about the issues raised tonight, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. You can also download, this is fairly new, an audio file or podcast of tonight's broadcast from the website. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. Our thanks to the Department of Health and Ageing for making this programme possible, but thanks to you for taking the time to attend and contribute. I'm Norman Swan. Good night.